are familiar with the solemn pledge that physicians make when they graduate from medical school, citing Hippocrates and this notion of doing no harm and always doing the best for patients, it's not well known that the Hippocratic school of medicine is the foundations of evidence-based medicine. Here's another quote from Hippocrates: "It is worth learning from everyone, for people do not discover these by reasoning but by chance, and experts not more than laymen." Back in 500 BC or so, 480 BC. So it's a long time ago. We haven't really achieved this dream yet. And attaining this dream of evidence-based reasoning for real is going to take an incredible association between computer science and clinicians, as well as biomedical researchers. So on fueling this pursuit, significant advances were made via long-term funding over several decades. Critical NIH, NSF, ONR, and DARPA support for basic foundations of decision-making under uncertainty, representation, and reasoning. In the AI and medicine world, it turns out that critical NSF and NLM funding in the 80s, to mid-80s to late 80s, really ignited, because of the kind of the high stakes of the problem, the overwhelming uncertainty in the decisions that had to be made, a whole new approach at the time to machine intelligence, which really played a central role in AI becoming to what it is today, which is really a field centered not just on logic and theorem proving, but also on statistical methods, utility and probability, and the criticality of those methodologies. So we're in exciting times right now. Learning and reasoning prowess, sensing and interaction, ubiquity, computation and connectivity, as we've heard today. In some ways, believe it or not, in clinical medicine, we're still wrestling with a bottleneck because we're faced with the inadequate capture of data about patient care, hospital flow of activities, flow of control, even consumer health care right now. That's a critical bottleneck that we're working with. And if we can really solve that bottleneck through capture, work on electronic healthcare records, new approaches to monitoring, we really can enable new kinds of diagnosis, actions and policies, wellness and prevention, and discovery research. Now, back in the 80s, we started working without much data on representations that would prove to be critical for today's data-centric work. This whole area of probabilistic graphical models. How can we capture expertise, for example, in the case of this graphic here, of an intensive care unit physician, that would link primary diagnoses which could not be seen with observational evidence like heart rate, for example. On top of that, we've developed algorithms that could walk over these graphs, and for any set of observations being seen, could provide inferences on any hidden variable. And these methods were used working very closely with experts to build systems and prototypes like this one here that would do pregnancy and child care triage on the web. This went on the web in the mid-90s, in fact. And consumers could actually engage these systems and have one of those networks, those probabilistic graphs, reason like an expert in providing advice to a parent. Now, in the 90s, we really began to understand how to build those models by hand from data, running algorithms that can actually learn from the data and automatically, through a process of search, for example, in this case of Bayesian structural algorithms, build predictive models that could then predict from observations or streams of symptoms. And the idea was, and again, NSF and NLM and DARPA and NASA actually funded quite a bit of algorithmic work. Turns out it's an intractable problem in general to walk over these graphs and make inferences. So this set up a whole, I'll call it the backbone of modern evidence-based medicine, and the promise of going from a data set to an inferential model that can give us probabilities, like in that histogram, and then working with a decision model that can balance costs and benefits to actually take us down to where the rubber meets the road of action in, for example, a healthcare setting like a hospital. I'm going to just very quickly go through two examples to put some meat on the bones. I think we'll be very high level most of the talks today, to give you a sense for where we're heading with this kind of work. And the first example I'll talk about is reducing hospital readmissions. Now, about 2.5 years ago, there was a kind of a flurry of articles about the readmissions problem. One article that was in the New England Journal of Medicine cited that for Medicare patients, within 30 days, 20% were bouncing back to hospitals after discharge. and 35% in 90 days. And the estimated cost, if you would take these bounce backs as being avoidable, $17.5 billion per annum. That year was 2004 data. Now, just a few miles from here, we began working with the Washington Hospital Center, which is in the top 10 urban hospitals in the country. We actually acquired some fabulous software at Microsoft from that team that had been homegrown, which became core of what's been called Microsoft Amalga. But as part of that, we got access to an incredible data store that came because of some innovative capture this team was doing at the Washington Hospital Center. For example, 300,000 emergency department visits over almost 10 years, and then on patients, very, very detailed capture, admissions, discharge and transfer data, which is kind of standard, but also age and gender, demographics, diagnostic codes, labs and medications, vital signs and procedures, and so on. Taking about 25,000 of those variables, we began to sort of predict various kinds of target goals. For example, can we predict that this patient right now in the hospital would be readmitted within 30 days? Here's a graphical model we built. Let's focus on one of the models here, which says this patient you're discharging right now, the physician's looking at the system, will bounce back within 30 days to the emergency department and be admitted to the hospital with a serious problem with this probability you can read off. Now, when you build these models, the way you test them is you take training data, which is most of the years, and then you take the most recent years that you haven't looked at yet, that are hidden from your algorithms as test data, that little wedge of beige there, and then you say, how well could I do on these new patients coming in that I haven't seen before? And you get one of these performance curves, which tells you, for example, and these classifiers are never perfect, typically, how well you can do, what's the percentage of false positives versus true positives. So this says here, for example, we can get 75% true positives on patients that will bounce back within 30 days at a risk of 25% false positives. Well, it's a trade-off there. And given this kind of characterization of these algorithms, we want to put them to use in decision-making in a setting. Now, the other thing that the algorithms tell us, and physicians find this fascinating, is they give us an ordering over the evidential variables by how important those variables are in predicting this bounce back to the hospital in this case. For example, we see heart failure is an obvious one. It's a tricky disease to manage, and patients are in and out of the hospital. But the algorithm has discovered that patients that stayed 14 hours or more in the emergency department are hard to keep out of the hospital. And we went through all the free text entered on this patient and found out that the word fluid appearing on the chart is a bad sign for staying out of the hospital. These kinds of evidential subtleties are not readily available to human beings trying to scan a chart. So getting into decisions now, we want to basically ask ourselves, how do we use one of these predictive models in practice? And the basic idea is we want to look at the literature and find out what we might do to change, tilt the balance. So there's been a bunch of articles, really great articles on if you do X, Y, or Z, a post-discharge care program with 2 nurse visits, or scheduling an outpatient visit in 10 days, you can lower the readmissions rate, for example. And each of these programs has a cost and a benefit. And the basic idea is we can build a decision model now that actually takes that holdout set and computes for us the expected value of immersing this system in a hospital setting with a stream of patients that have not been seen before. So, for example, we find out, we train up a model on 4 years of data, 2004 to 2007, and test on 2008, and find out, okay, in 2008, there were 62,000 visits to the emergency department, over 2,000 bounced back in 30 days, estimated cost $44 million for the bounce backs. We can say, from the literature, run a $1,000 program on some patients that the algorithm tells us it's worth it, not all of them, and we save $2 million. Now, given the curve, we can now visualize this curve, which is really exciting to me in that we can say, well, I wonder if I can do the same kind of thing with new kinds of sensing and computing innovations, like a Wi-Fi scale for a congestive heart failure patient, or a mobile device, and we ride this curve, which has a geometric shape in terms of cost savings. Now, what's very exciting, we're showing this work to the Microsoft product team, we're in research, we could really start shipping predictive modeling in a real situations. We can translate the intuitions and insights into a real product. And we actually started working on the engineering aspects. And it turns out when you do translation, there's a lot of science and engineering that comes to the fore. So, for example, doing all those queries was kind of hard on all these patients every few minutes, given the server capabilities and the analysis going on per patient every few minutes. Let's back off and try fewer numbers of variables. Or, for example, some hospitals we found out are different than other hospitals. They don't have this kind of data store. We have to sort of use simpler variables. How well could we do, for example? And coming up with the right kind of trade so we can manage the performance curve and still ship a product that can go in other places is a very exciting and interesting real-world engineering challenge. Now, we went live in June at our first hospitals. I'm hiding all data here except for the probability of bounce backs. So these records are sorted by that right now. So this is actually look at the system and see the probability of bounce back for a patient. This is not making decision-making just yet, but it's actually advising on high-risk patients for bounce back. We learned a lot by turning the system on in different hospitals. It was exciting and frightening to have people in Louisville, Kentucky pull like a lawnmower cord and start this lawnmower, and it's automatically training and recommending outcomes on patients. To understand this transfer learning problem is very interesting and challenging in itself. Even understanding, can we really automate this versus do we have to always rely on expert hand-holding? For example, Microsoft Research gets this performance curve on every usage right now. We analyze it, take a look at it to guarantee quality. Now, I'm going to mention another whole area right now to give you another example with some meat on the bones here, another hard problem, which is medical errors and injuries. So there was an Institute of Medicine report, a classic one, about 10 years ago, that said nearly 100,000 errors are made in hospitals that lead to deaths per year, and a bunch of these are preventable. The report was called "Error is Human." It wasn't making fun of anybody. It just said this is a human problem. A recent report coming out of HHS cited adverse medical events in 13.5% of Medicare patients, almost half of which are preventable. And the cost of errors in an older study has been shown to be between $17 and $30 billion per year, another $30 billion figure in my slide deck. What can be done about this? In fact, recently, actually I'll say in January, there was a nice article in the New York Times citing a more recent report also about most errors at hospitals go unreported. We're not even collecting that data. And in fact, this report cited some comments by Dan Levinson of HHS that because these errors weren't being captured, hospitals were not even reacting yet to coming up with ways of handling them, making themselves better. Now, and there's lots of incentives coming out of CMS right now about that. Some fabulous work out of Pittsburgh, close colleagues at University of Pittsburgh Biomedical Informatics program, have been looking at methods to train up a model to detect anomalies. The basic idea here is that they took post-surgical cardiac patients and went through their records and looked at what are common things that are done and not done for these patients. Over 4,500 patients and creating 31,000 episodes to look at with a probabilistic model. By doing this, you can then build a predictive model that runs in real time. A new patient comes in here with a certain state of observations that are available, and the system is watching actions that are occurring and procedures, tests that are being done, for example, anticoagulant strategies, and it's basically computing, was that likely? That's an odd thing. And it's basically computing how rare an action or procedure or lab test result is, or how rare an omission has been. It becomes a safety net based on data to reduce errors. And there's a beautiful award-winning paper on this topic at the last AMIA conference. Another project that's in the space of error, which is very exciting for us, working again with Justin Gatewood and others at the WHC down the street here, is forecasting a physician's surprise. So this graphical model here actually was trained up and will forecast the likelihood that the patient you're discharging today will bounce back to the hospital in 3 days with a diagnosis nowhere on the chart right now. And by the way, do you want to take a peek at what the system's thinking? You might. And the basic idea here is, it's funny, we had the actual physician look at cases, and I'll say, wow, I could have seen that from a mile away. In fact, he just said this in email yesterday to me. upon review. Or, wow, that one came out of the blue. That's really surprising. It's very interesting to use these surprise models in a hospital because they complement human expertise with a machine's expertise. They address the frontier of human understanding about cases. Another big area I'll just mention quickly here is learning to predict hospital infection. I bet very few people in this room don't have an experience where a close family member or a friend went to a hospital for a procedure or situation X, was complicated and difficult, and that they came through that with flying colors, only to face a hospital-associated infection, which almost took them down or did lead to their death. 1 in 20 hospital visits are associated with infection acquired in hospitals. 5% result in death. Hospital-acquired infection itself is in the top 10 causes of death in the United States itself. $20 billion annually. Working with Jenna Weems and John Gutag at MIT. Jenna was one of my interns several years ago, and we're still working hard on this problem. We're coming up with really nice results to predict will this patient get infected with MRSA, VRE, or C. difficile in 48 hours or in 3 days in a hospital, and how would that change the strategy? What's interesting about this work is it's actually bringing up some deeper computer science in that we're seeing some of the evidence coming up and we're asking questions like, for example, is there a causal link between room number and illness? An MD's name, getting a certain analgesic, and so on. And looking at time and space. So it turns out that we can actually plot now with data a patient's course through a hospital, and that enhances our curves, those performance curves you saw. So let me just end there by just saying that it's not just these projects. In the last year or two, you can look at my slides, there's been some fabulous data-centric, insightful projects at universities and industrial labs across the country and world. Each of these 4 projects I put up here as an example framed research that led to new essential computer science. It enhanced our understanding of computing to be applied in many ways beyond healthcare, but healthcare was the motivation, the frame for these projects, each very exciting for computer science and for the field of machine intelligence. So I'll stop there, saying that input itself is a hard challenge. You come to my slides to see some of the really hard challenges coming out of health informatics, but it really is up to us to be faithful to the Hippocratic Oath, to join with physicians and biomedical scientists, raise our hands solemnly and say we will do the best we can to enhance healthcare. Thanks.
We may have time for one question.
I have a question for you, but in a way it also goes to what Eric Brown was saying, and that has to do with the sources of the data. Particularly when the data is about people. Forgive me, I'm back on the privacy wagon, but it's, first of all, a lot of the discussion of big data is, crowdsourced data. Go to the web and scrape the web for all this fabulous information. Even, systems like patients like me, we're going to get medical diagnoses. Or in some of the cases you're talking about, I'm sure you're using hospital generated data, in which case, isn't there some resource that's being exploited over here? What sort of questions can we ask about the quality of the data and whether people in society owe it to you to be providing the information about us into this big data business?
Well, let me say that privacy concerns with healthcare data, going back to legal issues like HIPAA, are very interesting and very challenging for the field of biomedical informatics. In that if we came up with a solution that allowed for some more sharing of data of this type, we could have faster paced innovation, but we also want to protect patients and actually act in accordance with patients' preferences. I think it was Russ Altman that wrote a piece on, it's really even hard to donate your data if you wanted to be an altruistic donor of healthcare data. And we need to allow for mechanisms like that. On the front of what we did, we work in a very tight, what's called a sandbox. All of our algorithms and inferences run inside the hospital itself, and we just take out abstractions and insights and these predictive models, which basically have really processed down to the essential relationships, patient data. But I think in general, we're all very excited at Microsoft Research about the privacy challenges. As you know from some of the work from some of our facilities, Cynthia's work and other people, we have decision theoretic approaches with cost-benefit trades. We're very interested in getting tools that allow people to actually assess preferences about what they share and how valuable it might be. In traffic, for example, the idea of understanding how to limit with valuable information applications, what I ask people, so you only ask people the data that will be most altruistically valuable to them and to their colleagues. So it's a very interesting set of challenges that cuts to the core of this kind of work. So good question, Helen.
Thank you.
Okay.